Hi, my name is Jonathan Alvarez. I'm a postdoc on the AQMed team in hardware engineering with a focus on medical devices prototyping. I did my PhD in wearable sensing and in mechanical engineering, and really my sort of focus on the team is both in prototyping new features for the medical device that we're building, as well as general systems level debugging to make sure that the device is reliable and robust on clinical deployments, making sure we're getting as good of data as we can. And I'm here with Amaury.
Hey, hi, I'm Amaury Leroy. I'm a data science postdoc, also at AQMed team. So I did my PhD in AI for biomedical imaging in oncology. Here at Sandbox, I get to transform real-world, messy and complex physiological signals into decision-ready and clean insights for the physician. So I work a lot with the hardware team, but also like clinical team to really bridge the gap between research prototypes and production systems.
I think one of the things that often resonates most with visitors to the lab or people that we're telling our story to is trying to walk them through the patient story. And so you can imagine in hospitals all across the country, all across the world, a patient, every day, every hour walks in with chest pain, and it's up to doctors to figure out what's going on. Is this they ate some spicy food and they can just be discharged, or obviously are they having an actual heart attack and they need to get to the cath lab immediately for treatment? One of the tools that people know best is EKG, which is electrocardiogram, and this measures the electrical potential of the heart as it contracts. And this can be measured with pads on the chest, and this is the sort of standard time traces you see in movies all the time, the beep, beep, beep as someone's being monitored. The problem with that is that in a very, very small percentage of cases is EKG deterministic enough to tell doctors what's going on. And so in those cases, of course, doctors know what's the problem and they send them off to the cath lab and hopefully everything is all right. But in the overwhelming majority of cases, EKGs doesn't have enough information for doctors to make a clinical decision as to whether or not these patients should be admitted. And so this patient that's now shown up into the ER is now put into observation for a indeterministic period of time as they await further tests. And the next test that's available, and really the test that doctors I think trust the most, but takes the most time, is a serialized blood draw. So they're looking for a protein called troponin, which is released when when muscle tissue in the heart is damaged. The problem is a single measure of troponin is not often enough information because that could get elevated from rigorous exercise or high stress. So really they need to look at the troponin levels in the blood hour over hour. And they're looking for sort of an increasing trend as troponin levels are increased, which is often a great sign or a large sign of heart attack. The problem with troponin is it takes a long time. So you can imagine, you really think about patients' journey during a heart attack as this like really stressful and overwhelming time, but often it's actually a time of boredom and stress. They're just sitting in a bed. They have no idea what's going on. Doctors don't really know what's happening and are not necessarily able to communicate with them in real time. So they're sitting there. And it's really in these hours that we're hoping our device can make a real impact. And so our device is magnetocardiography, as obviously you know, but in telling this story, I think this is really where we paint the picture of this is where MCG slots into the clinical picture. So it's not meant to replace EKG, but it's just adding more information to the doctor's toolkit to make a decision as to whether or not they should admit the patient to the cath lab or they can safely discharge them. And so maybe it's you can tell us why, obviously MCG has been around for a long time, and some of the visitors we have or some of the people we talk to mentioned this. And I think the classic retort is that while it's been around for a long time, it's not necessarily the most practically useful tool in its previous iterations.
Yeah, actually, I think it's been around in about like the 1960s, something like this, but it faced huge technical problems. So the first thing is that the Earth magnetic field is incredibly faint. It's about 1 million times weaker than the Earth magnetic field. So because the hospital environment is full of devices like monitors, elevators, or other power lines, it can completely bury the Earth signal. And the second thing is that in older MCG devices that needed usually these shielded rooms to function, the sensors also needed ultra low temperature to work. So it meant cryogenic cooling plus high maintenance, very high cost. MCG has been stuck between being really nice in theory, but completely impractical in hospital clinical use.
Yeah, I think maybe one of the other important points that maybe isn't so clear is obviously for the sort of fundamental physics, like people are aware that the EKG and MCG are sort of arising from the same signal. So it's the current that's flowing in the heart, which generates both electric potential and a complementary magnetic field. I think one of the key things that, is important that we try to make people aware of is the difference between EKG and MCG is these electrical potentials dissipate through body tissue. And so you're measuring them at the surface of the chest, but people have various levels of skin and fat and different tissue that distort the electrical signals as they propagate outside of the chest. The flip side is the magnetic field, which passes virtually unperturbed through the chest. So it comes through closing, it comes through the chest wall and the ribs and bone. And so you're getting this really pure signal of the heart current. But it's exactly actually that problem, which is why you need to shield the rooms, because just like the heart's magnetic field emanates without any distortion from the heart, so too do lights, does Earth's field, someone walking down the hall with an oxygen tank, an elevator moving up and down. And so I think that's really where the sensing technology can only get you so far, and it's really up to the data science team to really work on signal processing and eventually like classification of that data.
Yeah, so signal processing is really important to get a clean signal. Once we have this clean signal, the next step is to make sense of it. So basically, that's where our AI models comes in, because the waveforms of the magnetic field is not really like self-explanatory. The physicians are not trained to read them, so we have to inject something new. So basically, we develop large quantitative models, or LQMs, to basically like. These LQMs are pre-trained on millions of synthetic data that we generate from physics-based transformations, plus fine-tuned on our real clinical data, so that we can detect subtle patterns of the heart activity.
Yeah, I think that's a really important point, which is that physicians aren't trained to look at MCG data. And so if you just show them the raw data, maybe you and I can look at this and certainly not make a clinical diagnostic, but we could say like, okay, this looks like a healthy heart, or maybe looks like a diseased heart. But it's really on the onus is on the data science team to transform that data into something that's meaningful to a clinician to either read, or a number, or a score. Yeah,
so there is this classification, which is really important, like to give a diagnostic, but we focus a lot on interpretability, because like we cannot give like the physician a yes or a no for a certain target indication. We have to explain also the why. And so we design a lot of physics-informed explainable features from the heart. We also give some uncertainty calibration, so that we give the physician a real answer, documented, that the physician can trust without any doubt, and with some real insights.
Yeah, and I think maybe the elephant in the room is like regulatory. So it's not enough to just show that this device works once or twice, or works in the lab, or works in a certain hospital, but there's really a massive burden of proof to get a device approved for wide clinical use and clinical adoption, and really clinical diagnostics. So a doctor can actually use our information to inform the diagnosis of a patient. And I think that that's really the next step in our team, is working towards regulatory pathways that allow us to start putting these devices in the hands of doctors, and not just saying, hey, like, isn't this such a cool technology? It would be great if you guys could use this, but actually allowing them to start using the device, using the reports that are generated from the data science team on the data we're collecting, and actually, affect real patient outcomes based on the information we're providing them.
So what excites us most right now is to work with real clinical partners. So Mount Sinai or Mayo Clinic, from which we acquire a lot of real clinical data. So it's really interesting to test our models against clinical tools that are existing in standard of care. So each successful recording, each successful diagnostic is a sign for us that our technology is ready in a few weeks, in a few months, in a few years to move into a clinical use. So moving forward 5 years, 10 years forward, our goal is to have the MCG installed into the standard of care, similar to the ECG, so that it means millions of patients being scanned with an MCG, getting precise diagnostic in minutes instead of hours, as you explained with Troponin, and just revolutionizing standard of care and improving patients' life.
Yeah, and then I think the last thing that maybe I speak for both of us here is that one of the really cool things about working at Sandbox and being postdocs, coming pretty much fresh out of academia, is the quality of scientists, engineers, regulatory specialists, like the quality of people that we get to work with on a daily basis is really remarkable. And I think it's like maybe one of the more exciting things. You come from academia where you're working around a lot of smart people, but you're kind of siloed in your individual project, or maybe you're working with one other grad student or postdoc. And then here you have a team of 20 plus, all hyper focused on the same mission. Really like leading experts in the field of data science. We have amazing signal processing experts, sensor experts, regulatory experts, product experts. And as someone starting their industry career, it's like there's like maybe no better place to work in terms of getting this experience, like really hands-on in a small team environment that is hyper focused on like a single goal. And I think that's been a really huge blessing as a postdoc here.
Yeah, it's true. Potential is huge. The impact is potentially huge for the patients. The team is great. The problem is really hard. And yeah, I agree that it's really wonderful to work in such a great team.
Thanks for watching. If you'd like to learn more, please subscribe to the SandboxAQ YouTube channel.